We are your hosts, Nikki Shore and Jesse Swain, and you are listening to the American Journal of Infection Control podcast, Science into Practice, brought to you by the Association for Professionals in Infection Control and Epidemiology to highlight work published in our peer-reviewed journal, ACHIC.
Join us as we speak to those in the field of infection prevention and control, like us, as well as other experts, to learn about some of the latest research in the field and how it can be put into practice. We hope you will listen in, learn something new, and apply this information to your work. If you are not a researcher already, we hope this podcast will get you thinking about areas where you can carry out your own research. Howdy, Nikki. How are you?
I am well, my friend. I like your usage of the word howdy. That's a Kentucky word.
So I think we finally just kicked off summer in New England. My family actually spent the last few days at the beach. I love the ocean.
Mm-hmm, me too, yeah.
Do you know how we know the ocean is friendly?
How we know the ocean is friendly?
Mm-hmm.
No. Tell me.
Because it waves. You know what's funny about that actually is that we talk about that in our neighborhood. We have a very friendly neighborhood, and when people don't wave, we take it very personally. So
yeah, yes.
Makes a lot of sense.
And in all honesty, I mean, that's the way we are in the South too. We always wave to people. So I get it. I get it.
Okay, we better stop messing around now and get to our guest, Dr. Danielle Durant. Dr. Danielle Durant serves as Principal Research Associate for Healthcare Delivery and Policy Research at Westat, a health services research firm. Previous to this role, she was assistant professor in the School of Nursing and Health Sciences at Texas A&M University, Corpus Christi, where she taught quality management and evaluation in healthcare for the healthcare administration program, among other courses. And while pursuing her PhD in public administration with a concentration in healthcare management and policy from Rockefeller College of SUNY Albany, Dr. Durant was employed for several years at the Healthcare Association of New York State in their Quality Advocacy and Research Initiatives Division. Within Quarry, and I hope I'm saying that correctly, she served as project management coordinator for the New York State Partnership for Patients program, a $15 million contract with the Centers for Medicaid and Medicare Services aimed at the prevention of hospital-acquired infections and other adverse events in New York State hospitals. Before her appointment at Hannes, Dr. Durant was a graduate fellow at the New York State Department of Health, working directly with the New York State Medicaid director on delivery system reform incentive payment program implementation, as well as policy liaison for implementation of the New York Medicaid Management Information System. She completed her PhD dissertation exploring 3 strategies for the prevention of hospital-acquired Clostridium difficile infection in New York State acute care hospitals, structure, process, outcome model of quality improvement in 2018, graduating with her PhD. Additionally, she has a BS in finance and economics, an MBA in management, and MS in engineering management, and is certified Six Sigma Green Belt with ASQ. That is amazing. That's a lot.
Sure is. Yeah. Congratulations.
Fantastic. Yeah. So today we are going to be talking with Dr. Durant about her paper, Evaluation of a Statewide Collaborative Focused on Antibiotic Usage Surveillance and Stewardship in New York State Hospitals. Thank you so much for joining us today, Dr. Durant.
Yes, thank you so much for having me and for that lengthy introduction. Sometimes I hear that read back and I'm like, wow, have I really done all of those things?
That's fantastic.
To be here.
Yeah.
Very cool. So Dr. Durant, could you kick us off today by talking about the main driver of the Healthcare Association of New York State Antibiotic Stewardship Collaborative in 2015?
Sure, absolutely. And we're going to be talking a lot about the Healthcare Association of New York State, so I'll just get that out of the way that we refer to them as HANYS, so HANYS, and we just pronounce that as HANYS. So I thought a good place to start is to just kind of describe what HANYS is. And just by the name, as it suggests, it's an association, right? And the job of an association, whether it's for a profession or an industry, is to promote the well-being of its members. And Haney's is like the association in New York State for healthcare organizations. We have some regional associations like Greater New York Hospital Association. That's going to focus on a particular area like New York City, but Haney's is like the state association. So they have really high membership, and members pay dues to get access to Haney's services. And in their own words, they work to advance the health of individuals and communities by providing leadership, representation, and service to not-for-profit and public hospitals, health systems, nursing homes, and other healthcare organizations throughout New York State. And so this is going to take the form of things like advocacy efforts, at the state and federal level for policies that are in the best interest of New York State healthcare providers, as well as providing services like the Antibiotic Stewardship Collaborative, which is, our focus of our discussion today. That was just one initiative happening in the Quality Advocacy Research and Innovation Division, like you said, QARI, of Haney's. And I thought it would be important to just kind of give some of my background of how I became involved in the collaborative. I was working in the QARI division at that time for a different initiative, as was mentioned, the New York State Partnership for Patients program, which was part of the larger, federal Partnership for Patients program. And I was also a PhD student back then with Rockefeller College of SUNY Albany. And my goal with working with Haney's at that time was, of course, to gain some awesome experience in the healthcare field, but to also be able to collaborate with Haney's on projects that could satisfy my PhD candidacy and dissertation requirements. So conducting an evaluation of the Antibiotic Stewardship Collaborative became one of those projects. And it worked out really well because I had not been involved in the collaborative, so I was able to kind of step in as a sort of kind of independent outside observer researcher. But with that background in place, I'll get back to your question in terms of, what was the impetus for the collaborative? And it officially launched in 2016, but it was being conceptualized by Haney's in, around late 2014 and into 2015. I'm estimating these dates. It was a long time ago, almost a decade at this point, with recruitment occurring in the final quarter of 2015. And at that time, if we can remember back, antibiotic resistance and stewardship were very much on the federal and state healthcare agenda. So there were kind of some key pivotal moments that led to thinking we need this collaborative. In 2014, the Obama administration released a national strategy for combating antibiotic-resistant bacteria that was accompanied by an executive order directing the U.S. Department of Health and Human Services to establish a presidential advisory council to review existing regulations and propose new regulations or other actions they sought fit to require hospitals to implement robust, in their words, antibiotic stewardship programs that adhere to best practices. And that same year, the CDC called on all hospitals in the U.S. to implement antibiotic stewardship programs and released the core elements of hospital antibiotic stewardship programs, or the core elements. Around that same time, NHSN added the antimicrobial resistance option to the existing antimicrobial use option, creating what we're going to talk a lot about today is the antimicrobial use and resistance module. And then 2015, so around the time the collaborative was starting, the United States National Action Plan for Combating Antibiotic-Resistant Bacteria set a goal for implementation of the core elements in all hospitals that receive federal funding. So as an association that is working for the well-being of its members, it's Haney's job to kind of keep a finger on the pulse of how healthcare is changing and provide assistance to its members to ensure they're adequately prepared for these kinds of policy changes or new requirements. And so the leadership of QARI just felt very strongly that the political winds, so to speak, were blowing towards required reporting in this new NHSN module. And infection preventionists are likely very familiar with reporting in NHSN, right, for HAIs like CAUTI and CLABSI, kind of as a CMS requirement. But at the time of this antibiotic stewardship collaborative, reporting in the AUR module was only encouraged but not required. And they conceptualized the Antibiotic Stewardship Collaborative with two aims, thinking that reporting in that module was going to become required. The first aim was to prepare hospitals for what they believed would be that mandated antibiotic usage reporting, and then to assist hospitals just generally in developing those robust antibiotic stewardship programs based in best practices and just to help them prevent MDROs. So I know a long answer, but I felt like I needed to fill in some background information for y'all.
No, that's great. Thank you.
Yeah, it is. And that's very detailed, because I was going to ask you, do you mind going into more details on the module of the antimicrobial use and resistance, or as the infection preventionists might know it, the AUR module for NHSN?
Mm-hmm. Absolutely. So I'm not an expert, but I can absolutely give you kind of an overview of kind of the intention and objectives behind the AUR module. It's really there to provide a mechanism for facilities to report and analyze antimicrobial use and or resistance data. So there's the two options, and they can, folks can report in one, the other, or both. And this is to inform benchmarking, reduce antimicrobial resistant infections through stewardship, and interrupt transmission of resistant pathogens at individual facilities or through facility networks. As I mentioned, there's the two options. There's the one focused on use and the second on resistance. And I'm going to focus on the usage option today, as that was the primary emphasis for the collaborative. And to participate in either option, though, and this is a really important point for today's discussion, a facility must coordinate with their pharmacy in the case of the usage option, or their laboratory in the case of the resistance option, the software providers and systems that they use in those areas to configure to be able to generate standard formatted files in order to report data in these options. There's no manual reporting allowed for these options. And
that's interesting.
The primary objective of the antimicrobial use option is to facilitate that risk-adjusted antimicrobial use benchmarking within and across facilities, as well as to evaluate antimicrobial use trends over time at the facility and nationally. And one output measure that they use in that AU option is the standardized antimicrobial administration ratio, or SAR. And this is a risk-adjusted benchmarking measure of antibiotic use. It's not unlike the SIR calculations, right? That has that denominator that's trying to kind of predict based on like facilities, similar kind of concept. And that's just to inform stewardship efforts by enabling hospitals to kind of see how their antibiotic use compares to other facilities.
That's really interesting, and it actually makes me think a little bit about how, depending on where you're located and what your patient population looks like, that could potentially alter your antibiotic usage as well, based on your antibiogram, I would assume. So the Antibiotic Stewardship Collaborative was described as having two aims: incentivizing participating hospitals to develop the necessary infrastructure for reporting in NHSN's AUR, and educating the participating hospitals on antimicrobial resistance, multi-drug resistant organisms, and antibiotic stewardship. So how did the ASC intend to meet these aims?
Sure. So as I'd mentioned, manual reporting and the NHSN AUR module is not allowed. Instead, facilities have to coordinate with their pharmacy and or like laboratory information software to configure the systems to generate the necessary reports in order to provide that data to NHSN. So Haney's incentivized developing the necessary infrastructure with pharmacy, right? Because they were focused on the usage side, by offering hospitals an opportunity to submit their antibiotic usage data that would otherwise be uploaded to the NHSN AUR module to Haney's directly. And they did this in return for individualized hospital and aggregate benchmarking reports, that was meant to kind of mimic the sort of analysis that was available to facilities reporting into NHSN. Hospitals were asked to collect data for a small subset of antimicrobial agents, reporting agent-specific and facility-wide days of therapy per patient days present, with the goal of getting to unit-specific reporting. Again, trying to mimic this functionality in the NHSN AUR module. Haney's provided just a simple Excel workbook, and data was to be submitted monthly to them. This offered a mechanism for hospitals to begin exploring their usage data without any sort of judgment or expectations, with the ability to see kind of how they compare to like hospitals. This ability to set up like the infrastructure and sort of kind of go through the steps or trial reporting to NHSN and kind of reacting to the comparative reports and putting these processes in place without anything kind of being on the record, kind of like a safe space provided a powerful inducement. We had, a lot of uptake in terms of those that agreed to join the collaborative, actually setting up this infrastructure. And the overall goal of the collaborative was, for this aim of it was to get 95% or more of participating hospitals conducting active stewardship surveillance and as demonstrated by submission of at least 6 months of data from kind of the beginning of the collaborative until they were about, 6 months through. And they achieved this goal. By the end of the first year, all hospitals had reporting capabilities in place. Some took longer than others, but most were up and running and submitting their data to Haney's within the first 6 months as planned. And on the event side, so the second aim that you mentioned was just to kind of provide this education around best practices for preventing MDROs, as well as setting up those antibiotic stewardship programs. We used like this collaborative approach in this case as well, just like the comparative reports. We provided education that offered a space for hospitals to share their experiences as they were testing and kind of formalizing a new stewardship practices, as they were beginning to collect and analyze data. These events offered a space for sharing of like lessons learned, as well as hearing best practices from, some of the leading experts in the field. And these events were open to all of Haney's members. So whether they had officially joined the collaborative by signing a specific memorandum of understanding or not, we felt like it was important to still offer this to anyone who wanted to participate in this education to get hospitals moving in the right direction, even if they couldn't fully commit to joining the collaborative and begin tracking their antibiotic usage data. And these events began with kind of some recruitment topics in the beginning, trying to get people fired up about the collaborative, as well as how to make the business case, which we'll, learn in a little bit was really important, for their leadership, trying to get them on board of, why it was important to join the collaborative, as well as best practices for antibiotic stewardship programs. But then they started moving into other topics related to how do you track your performance in an antibiotic stewardship program with data? What are some of the issues you might encounter with active surveillance of antibiotic utilization, usage data to drive process improvement, et cetera? It was kind of like a monthly webinar series related to kind of some of these more general topics for managing their antibiotic stewardship programs.
Oh, there's a lot going on there. That's fantastic.
It is a lot.
It really was a really robust initiative.
Yeah, no. And I noticed that out of 184 hospitals that were eligible to participate, only 44 chose to. So what were some of the reasons that you think may have contributed to participation or lack of participation?
Yeah, absolutely. One of the main objectives of this particular paper or in this evaluation project, just generally, was to determine, could we figure out, is there a particular type, kind of in quotes, of hospital that was more likely to join a collaborative like this or not, right? Can we figure out, just based on, who's in the collaborative, are there certain characteristics that seem to predict who's more likely to participate? And what we found in the analysis was actually not all that surprising. It was hospitals joining the collaborative had significantly higher annual total discharges. So we're talking larger facilities, compared to those who had opted out. We had more representation from urban areas, especially the New York City region, more representation from major teaching hospitals, compared to those not participating. And we really took this to mean, hospitals with more resources are more likely to join a collaborative of this nature. And when we interviewed key informants about their decision, to join or not join, for many, participating in the collaborative was the next logical step in their antibiotic stewardship journey, as they had already had robust resources devoted to these efforts. It was easy for them to get leadership buy-in and to, start setting up the infrastructure to start reporting antibiotic usage data. But for others, they really just could not get leadership buy-in to support their work, this sort of work, the work that would be required, right, to get pharmacy systems configured so that data could be reported. It needed, a champion, right? They needed an outside person to really say, yes, we're going to do this, because it meant, working across departments. It was kind of outside of the managerial jurisdiction, so to speak, of the average infection preventionist or pharmacist or whoever was kind of leading the hospital's antibiotic stewardship efforts. And this proved difficult, right, to sometimes find this champion. And those same hospitals, that opted not to join, many cited that there were so many concurrent initiatives going on that are competing for resources. At the time, we were also doing New York State Partnership for Patients, which required a lot of time and attention from the infection prevention teams at facilities. And in these smaller hospitals, right, where everyone wears many hats, it can be a lot to try to take on another program. And so I really think this was a difference of, who's got the resources available and who doesn't. And kind of as a side note, and now that I work at WestStat, which you mentioned is a research contractor for CMS and other HHS agencies, I can see this pattern being repeated at a much larger scale. It's the same challenge, CMS experiences in getting participants in some of the healthcare delivery and payment models that come out of the Innovation Center. I'm working in programs like the Primary Care First and accountable care organizations, realizing equity, access, and community health. That's ACO REACH models. And they share this same struggle of representation, right? With large urban facilities more likely to participate in these programs. They've made it a priority, though, to try to find new ways of reaching a more diverse group of participants to ensure, equitable patient outcomes. So this is something that is a struggle, not just at the state level at a healthcare organization like Haney's, but also at the federal level, right? Is we want to see healthcare improvement and we want to see it on a large scale, but not all hospitals are the same, right? Some have far more resources than others and can kind of scale up or down as needed to kind of take on initiatives as they present. So that was the biggest challenge.
Well, one facility stated, I'm going to quote, a more formal and concerted push from Haney's regarding the importance of joining the collaborative would have helped get the buy-in we needed. If it was somehow a mandate or more like a mandate, it would have potentially provided the leverage needed to get the necessary resources allocated. So do you know if Haney's has the ability to mandate that in any way?
Yeah, so I really love that quote, because the whole point of the collaborative was really that we thought mandates were coming down the pike. And yet, even though, Haney's wasn't mandating, we're trying to get them prepared for future mandates, but they're well, we can't jump in on this unless we're being told we have to. And we're like, it's coming. So it'd be great to be prepared. So anyway, I just think that is it's a reflection, though, of that type of hospital that is really, struggles with resources. They have to prioritize things as they come down the pike. And when things are then mandated, it's like, okay, now we have to devote we have to make this a priority. We have to devote the resources to it. But, as an association, Haney's, members pay dues to them to kind of get access to their services. And some of what Haney's provides, advocacy at the state and federal level to preserve kind of the interests of its members is going to be equally provided to all, simply by its nature. There's nothing a member kind of has to do to opt in or opt out of kind of the general advocacy and representation kind of services that Haney's provides. But other services that they provide are offered as programs that members can choose to participate in or not. They're kind of offered, I guess, free, in quotes, to members that are paying dues. It's voluntary. Ideally, facilities will want to maximize what they get for their membership dollars and participate as much as possible in the sort of programming that Haney's offers, specifically saying it's meant to address their unique needs. But they're not about mandating anything. It's just not their particular role. They serve as an ally to their members. They really work hard to kind of maintain this perception of, with members that Haney's is there to serve them. They're not there to judge their actions or tell them what to do, which might be the perception some of these organizations have of the state and federal government and accrediting organizations. Those are the groups that kind of tell us what to do. And this really works in Haney's favor, right? That hospitals often feel comfortable kind of sharing with Haney's stuff that they maybe would be more hesitant to share with other external entities. And so they really try to preserve that. So it's really not heavy-handed most of the time with these offerings. They really just try to encourage and support as much as possible to get facilities to participate in these things that they have designed kind of in their best interest. But again, it's always ends up being, a resource problem sometimes.
Yeah, I find that comment particularly interesting as well, and my thoughts were exactly the same as yours. If it's something like Joint Commission or CMS coming in, and then that there's regulatory requirements, but until something like this is a regulatory requirement, then it's at least nice to have the support of something like Haney's to help you move forward with wherever you are in this process. And it's unfortunate that folks couldn't get the buy-in that they needed to get something going. But I'm sure as we move forward and this becomes or continues to be a major initiative, that people will begin to get that buy-in as regulatory backing occurs as well. But based on the feedback from some of the interviews with participating facility personnel, one appreciated outcome of the ASC was the comparative reports on antibiotic usage, which I also think seems really cool. Can you talk a little bit about these reports and like how those facilities use them?
Yeah, absolutely. So we've already touched on it a little bit. So, but I will kind of refresh. These were really meant to mimic the kind of reporting and analysis that could be done in the usage option of the AUR module for NHSN. Again, trying to offer this kind of judgment-free space for hospitals to kind of start reporting on some of these measures, thinking that this might become mandated soon. So they were just asked to collect data for a very small subset of the antimicrobial agents. Like I said, agent-specific facility-wide days of therapy per patient days present, with the hope of that they would eventually get to unit-specific reporting, which is supported in NHSN's AU module. So trying to kind of get them prepared for being able to use that module to its maximum potential. And they were given that Excel workbook so that they could submit to Haney's monthly. And then Haney's would then take that monthly data, and they would match kind of the usage amounts to similar facilities. So they had come up with a formula to try to match facilities in the collaborative together, kind of group them together as like facilities, similar again to how NHSN is coming up with that SAR for benchmarking. It was a similar kind of methodology, really just trying to, again, as much as they could reflect what hospitals could expect in the NHSN AUR module, Haney's tried to do kind of on a small scale. So they were matching facilities that they thought were like those facilities so that when they got these reports, they could see their own usage, but they could also see the usage of those specific agents, the amounts that were being used at hospitals that were kind of similar to them. So they could get a sense of, it was really meant to just bring awareness, right? This was the judgment-free space of just take a look, so facilities could be like, wow, we prescribe such and such antibiotic at a much higher rate than similar facilities. Maybe we should investigate and make sure this is appropriate prescribing, giving our patient population. It really wasn't meant to kind of like demonize and be like, look at, we weren't like highlighting ones that were really high, versus others, compared to the like facilities. It was really just, here's your usage. Here's the usage of that same agent at other facilities that are like you. Allow this to kind of spur conversation right at your facility, some investigation. Maybe it's absolutely appropriate prescribing. Maybe not. Maybe some tweaks need to be made, but allow this to kind of just be the impetus for these important conversations around appropriateness of prescribing.
Just education to the hospitals. And now I noticed that speaking of education, webinars were one of the methods that were used to educate the hospital personnel. How effective do you think that was?
Yeah, absolutely. So it was interesting feedback. We did these key informant interviews to get perspectives on, all aspects of the collaborative. And what we heard from folks participating was that the educational programming was really actually well received in the beginning. Hospitals felt like it started to become repetitive over time. They felt like as they were progressing in their antibiotic stewardship journey, they didn't feel the material was kind of moving forward with them. And probably this is because we had people joining the collaborative at different times. And, every hospital's at a different stage in terms of, when they're stepping into the collaborative, how far along they are on their antibiotic stewardship journey. So it's hard to kind of tailor to specific needs. So there were some facilities that were really feeling like, especially those that were like really engaged in the collaborative and really diving deep, that the education just it started to not offer them as much as it did in the beginning. It wasn't progressing as they expected it to, kind of as they progressed on their journey. So that was the main piece of feedback. They also mentioned that competing programs like New York State Partnership for Patients, like they all tend to use the same experts for each topic. So, Partnership for Patients focused on a lot of different initiative areas. Some of those overlapped with the collaborative, CDIV, other MDROs. And there seems to be these specific experts, right, that kind of go around and do a lot of these events on each of these topics. So they felt like it was kind of repetitive. They were always hearing the same perspective and they wanted some greater diversity. But one of the things I thought was most interesting was they felt like they got the most value when it was other hospitals sharing their experiences of what they did, what worked well, what didn't work well, like the lessons learned. And I really think that is just so awesome when you think about that was what this was meant to do as a collaborative, was bring hospitals together so that they can kind of share their journeys and grow together. And that's actually what they valued the most. And the whole point of this evaluation rate was to provide feedback to direct the progression of the collaborative in the future. And I really think Haney's did take this feedback to heart and made adjustments in future years of the collaborative.
Yeah, it's really good information for hospitals for sure. And what do you think were some of the limitations of the study?
Yeah, so there's always limitations to any study, and we have a few that are fairly big. I think the biggest was our outcome. Ideally, it would have been a direct measure of the collaborative. So it hasn't been mentioned yet, but we looked at CDIF kind of on a quantitative level. We obviously got the qualitative feedback from our participants in terms of what could be made better about the collaborative and about their experiences. But on the quantitative arm, we really wanted to see like what impact is this having? And so we looked at CDIF rates, for hospitals in the collaborative versus those not in the collaborative. And what we found, unfortunately, was that we didn't move the needle for participating hospitals on CDIF at a greater rate than we did for those not participating in the collaborative. And honestly, the biggest reason for this, I think, even though I do think it is clinically a significant progression that we had made, the biggest reason for this is that it was kind of an indirect measure, looking at CDIF rates. So when you think about what the collaborative was meant to do, hospitals needed to first develop the infrastructure to track and report antibiotic usage. They then needed to start receiving the comparative reports, have time to digest those reports with their staff, and then make practice changes that could then have subsequent impact on CDIF. So there's a lot of steps that have to happen before we're going to see change on infection rates. And we only looked at 12 months. And some people started immediately and got their reporting up and going immediately. Other hospitals joined a little later, and it took them longer to get their reporting up and running. So that outcome, being an indirect outcome, was kind of the one that was the most challenging. We had reviewers, right, tell us like, well, why didn't you look at change in antibiotic usage? But it's very tricky, right, to look at the antibiotic use and try to determine if progress has been made. Use of particular types of antibiotics and the quantities should be highly driven by the patient population. And we didn't have that information. So we couldn't necessarily assess if one hospital's usage is appropriate versus and another is inappropriate, you know what I'm saying, without having specific patient details. So a decrease in one antibiotic and an increase in another for a facility could indicate a move towards more appropriate prescribing, but those changes at another facility could indicate a move to more inappropriate prescribing. So without knowing the patient population, we couldn't evaluate if any changes were a move in the right direction. We could have probably designed something that assessed if changes were being made, like, period, without an attempt to try to label them as good or bad. But again, we felt like this was, not very good data to try to assess whether things were moving in the right direction. And then the other big thing was that we sold the program to facilities as a non-judgmental, consequence-free opportunity to begin exploring antibiotic usage and how a facility's usage compares to their peers with really no expectations attached. And we felt like if we analyzed that usage data, that we would be kind of violating that understanding, right, that we had with these facilities. And it was really important to Haney's to really not send that message of like, we told you this was like a judgment-free zone, but then we did this analysis to really see whether or not you were, getting better or worse, quote unquote.
Yeah, that's really funny that you say that about the C. diff. I was actually going to ask that very question, and in my mind thinking like that any reduction noted would be, as an infection preventionist, a win. But also, as you mentioned, you would have to do some serious case reviews to determine whether or not the antibiotic usage was appropriate or inappropriate. So that, I imagine, would be extremely time consuming. And I don't know how much value would necessarily be taken from that. But it was also noted that all the 44 participating hospitals actually successfully developed an IT infrastructure necessary to track and report their antibiotic usage data. So I'm just wondering, did the success of this initiative inspire considerations for more collaboratives?
Yeah, so I love this question. I know that the first year of the collaborative, which, I could mention too, that's another significant limitation. It's just we only looked at it 1 year. There was, Partnership for Patients was just getting busy with looking at MDROs and antibiotic stewardship programs as its own initiative area around 2016. So future evaluations would have had that as a confounding issue of like a concurrent program kind of going after the same things. And there were some other reasons why we just kind of looked at that 1 year. But I know that the success of the program absolutely kept it on the books going forward. So I unfortunately moved on from Haney's. I know it was still going when I moved on in 2018. At that point, I was just kind of working as a consulting researcher for them to just finish up some projects we had in the queue. So I was out of touch with the Antibiotic Stewardship Collaborative, but I know that as I left, it was still going on. So at the very least, it inspired it to continue. And I know more hospitals kind of joined on. And I know that means more hospitals got themselves prepared for this sort of reporting. But what I think is really interesting that I really wanted to mention was that the leadership of Haney's was so on track with these requirements. They were maybe a bit off base with the timing, I think largely because they didn't predict COVID-19. And I believe if it hadn't been for the pandemic, we would have seen a move towards mandating the NHSN AUR module already. And what I didn't realize with publishing this article is like, it's fairly timely. Like this is now back, on the agenda. I saw some changes have happened recently that is, making this a requirement in some instances. For instance, this year, CMS is finalizing several proposed changes to the Medicare Promoting Interoperability Program and modifying specifically the Public Health and Clinical Data Exchange objective to require an antibiotic use and antibiotic resistance measure, beginning with calendar year 2024 EHR reporting. So this is a mechanism clearly to push facilities to get that infrastructure that Haney's was pushing them to get set up so that they can be compliant with that particular program, because it's something that the government really feels is important that we move forward on. And then effective January 1st, 2023, new and revised antibiotic stewardship requirements came in to all Joint Commission accredited hospitals and critical access hospitals. These are requiring antimicrobial stewardship programs to track antimicrobial use as a required element of performance. And this is element of performance 16. It's new, and it specifically states the antimicrobial stewardship program monitors the hospital's antibiotic use by analyzing data on days of therapy per 1,000 days present or 1,000 patient days, or by reporting antibiotic use data to the National Healthcare Safety Network's antimicrobial use option of the antimicrobial use and resistance module. So now a part of Joint Commission standards as of 2023 that the hospital will do one of those two things, one of them being reporting in that antimicrobial use option. So we are seeing a move towards requirements around this particular module. And I think Quarry's staff, their leadership was just so kind of on point to kind of see down the road. They were maybe a little off with the timing, but again, I think because the big disrupting factor was kind of COVID-19 happened. Otherwise, I think we would have seen it kind of much sooner. So I thought that was very, very interesting.
It is interesting. And I also think it's interesting that, sometimes Joint Commission actually has more sort of specific regulatory requirements than even CMS has. So it's almost a little bit here like CMS is lagging a little bit behind because I know in our health system, although the critical access hospitals are not necessarily meeting all of these Joint Commission standards, we're actually trying to bring them up to speed with the Joint Commission standards, even though they are CMS surveyed, so that we're all doing the same things and we're all meeting those Joint Commission standards anyway.
Yeah, and what you typically find is like the government then usually falls like right behind. So if Joint Commission is requiring it now, we can expect that there'll be more specific requirements around that coming from CMS, I feel like in the very near future.
Yeah.
Well, tell us some key takeaways from the study and what you want our listeners to kind of take from this.
Oh, great question. So I think what is an important takeaway is that the collaborative approach to kind of solving big problems that we have in terms of healthcare delivery, whether it's patient safety or some other sort of quality topic, the collaborative approach is like really effective for achieving those objectives. Even though we didn't see significant change in C. diff rates, we got all the hospitals that were participating in the collaborative on board with this big challenge that they had, right, to get their IT departments help in getting pharmacy data set up in a way that it could be, standardized, reported in this AUR module. That was a heavy lift, right? 44 of the, all of those that were participating actually achieved this objective. And then for the educational piece, they really, participating hospitals really enjoyed coming together and sharing best practices with one another. They want to hear from their peers. And Haney's is kind of a great place to actually offer this opportunity for hospitals to come together in kind of that judgment-free, safe sort of space. And so maybe another takeaway is that associations can play like a really important role in quality improvement, particularly in healthcare, by offering this safe space for hospitals to come together, by keeping an eye on how things are changing and staying at the forefront and offering services that get hospitals prepared. I also think it's important to understand that change takes time, right? And so, with 1 year of an evaluation period for this particular project, we're not seeing all the things that we hoped to see, but we were headed in the right direction. Sometimes folks want to see change really fast, but change can happen really slowly, particularly in healthcare, as you're getting so many people kind of on board with moving in a new direction. So it's important to kind of just have some grace with that. Real change, takes time. And then I would just say these sorts of collaborations, so I was kind of in the academic side and I collaborated with Haney's in order to do this, as well as a bunch of other research, are just really, really powerful. I've worked with infection preventionists in my capacity as a professor, just helping them answer questions that they just don't have time to get to in kind of their everyday life. And as professors, we would have to do research, right, and publish as a big part of our job. So it's kind of mutually beneficial, right, for hospitals to kind of reach out and connect with folks on the academic side to help them evaluate programs and answer important research questions that they might not otherwise have the opportunity to get to. It allows us to come up with some of these findings. Haney's just did not have the time or capacity to do such a deep dive. It just happened to work out that I needed a project to satisfy my dissertation requirements. And subsequent projects I worked on with them, again, were things that they weren't otherwise going to get to with their current resources. But I was like, hey, I need to do research and publish, and this stuff is very interesting to me. This is a great partnership. And we continued to work together so that I could continue tackling topics that they thought were important that they just didn't have the chance to get to. So collaborating with academia, right? Healthcare and academia can be very, very synergistic.
That's great. Thank you.
Yes, fantastic to have you on. This was a lot of good information that infection preventionists everywhere are dealing with. So appreciate your info.
Yeah, thank you so much for this opportunity. I just love your podcast in the beginning with the silly jokes. I bring your personality to the table. I just so enjoy it, and thanks so much for this opportunity.
Absolutely. Thank you for being on here. We appreciate it.
AJIC Science into Practice is created by the Association for Professionals in Infection Control and Epidemiology with input from the APIC Research Committee and Pat Stone and Jean Brandt at AJIC and APIC staff Shanina Knighton, Chris Ruiz, Bobby Gulshan, Christine Miller, Kaylee Deaton, and Kelly Lynn Russell. We work in partnership with Human Factor and audio tech Blake Alphin. To hear other AJIC podcast episodes and to access information about this podcast and the field of infection prevention and control, go to our website at ajicscienceintopractice.org. That's AJIC scienceintopractice.org.